let us start with the definition of the supraglottic airway devices. This supraglottic airway devices secure the upper airway, keep it patent, and provide unobstructed ventilation in spontaneously as well as in mechanically ventilated patients. So the question arises: why there was invention of what led to the invention of the supraglottic devices and how they were invented? As you all know, Dr. Archie Brain is the man behind the invention of the supraglottic airway devices. Once he was working as an anesthetist at Seychelles, where while working he encountered too difficult airway. And from there, his quest to make a device which should be more reliable than the face mask and less invasive than the tracheal tube began. And this was also in his mind that he should invent a device which should be more effective and easier alternative to the endotracheal tube. So there was an fortunate coincidence that he has to get one dental case done where he used this Goldman nasal mask. And the idea struck his mind, why can't he use this flange and cuff over the endotracheal tube, which is cut in this way? And he started working upon this. After his hard work, he could make this a spoon-like bowl with an endotracheal tube. Then with many changes, ultimately he made this LMA, which is still kept in the London Museum. After having a conversation with many businessmen, even though he worked with the Dunlop business partner and ultimately made a classic LMA, the prototype of the LMA, which was launched in market in 1988. Now the question which could be asked in the exam is, what are the advantages of supraglottic airway devices over endotracheal tube? Supraglottic airway devices, they are less invasive, easier and faster to insert. They avoid laryngoscopic response, which are hemodynamic perturbations during laryngoscopy and endotracheal tube intubation. It is less traumatic, and these devices can be put even in neutral position, if not in neutral, with less neck extension, and it has an easier learning curve. Disadvantages are that there are risk of aspiration of gastric content. However, with further improvisation in the safety profile, this is also reduced to a greater extent. Now coming to the indication. What are the indication of supraglottic airway devices? As we all know that in our day-to-day practice, we are using supraglottic airway devices as airway management device for anesthetized patient, whether the patient is spontaneously breathing or paralyzed. And with the improvement in the safety profile, these can be used in wide variety of patients like obese, pediatric patient, and even in surgeries like laparoscopic surgeries and positions like lithotomy position. These devices are also used as an airway rescue device in case of difficult ventilation, like an obese patient, edentulous patient, those with facial tumors or deformity, patient with beard, and even reduced mouth opening. It is also used in emergency resuscitation and pre-hospital care because it has an easier learning curve and requires less time of insertion. It is also used as a conduit for endotracheal intubation in case of difficult intubation, failed intubation, difficult laryngoscopy, or failed laryngoscopy. Following are the few examples which can be of supraglottic airway devices which can be used for as a conduit for endotracheal intubation: LMA Fast Track, iGel, AirQ, Ambo, or again Blockbuster. It is also used as an aid in extubation, especially in patients like neurosurgical patient, cardiac patient, where hemodynamic perturbation may affect the patient profile, safety profile, and as they are used as an aid in Bailey's maneuver. It is also used in visualization of the vocal cord after thyroidectomy, and it can also be used when face masks can't be applied. It is used in ICU in providing percutaneous dilatation tracheostomy or while doing bronchoscopic procedure as an additional aid. Now moving on to the classification of supraglottic airway devices. Supraglottic airway devices are are classified in various ways. Based on evolution of the supraglottic airway devices, Cook classified these as first generation, second generation, and third generation. First generation are nothing but they are the simple breathing tube without having any specific design or feature that will provide protection against the aspiration risk. And the example of these are classic LMA, LMA unique, Cobra LMA, laryngeal tube airway. However, in second generation, what has been done, there was provision of for venting of regurgitant material. That is, there was addition of the gastric tube, and even there were more evolved cuff tips, which would provide better esophageal seal, as in Procel LMA, LMA Supreme, SLEEPA, Combitube, LTS D with laryngotube suction, or again, etc. In third generation, apart from the above features, it also incorporates dynamic sealing mechanism. That is, the cuff shape will keep changing with the intermittent positive pressure ventilation and will provide better sealing. For example, Basca airway mask, SLEEPA 3G. Based on the sealing mechanism, this was proposed by Miller, and based on the sealing mechanism, whether they are providing seal at the laryngeal level or at the pharyngeal level, or the cuff is anatomically pre-shaped to provide the sealing, they have been divided into three: cuffed perilaryngeal sealers, cuffed pharyngeal sealers, and cuffless anatomically pre-shaped sealers. Further, they are divided on the basis of location of distal end of the device in relation to the glottis. If the device remains superior to the glottic inlet, it is known as supraglottic device. That is, they seal around the glottic inlet like CLMA, PLMA, IGL, EMBU, Supreme, and retroglottic when they provide seal behind the glottis. And they will provide the seal around the upper end of the esophagus, like laryngeal tube suction, and combitube. Now, what baffles you that there are so many devices in the market, and in our armamentarium, around 27 to 30 devices are there. So it really scares that what device will be given in the exam and how will I proceed. So this is my advice to you: don't get scared. The basic anatomy of every device is same. If you are able to tell that basic anatomy, and rest of the information is written on the device itself. So don't get scared, just take the device, say the name of the device, and just divide it into two parts: airway tube and mask, and further information you can even get from the device itself. And if you are able to provide this much of information to the examiner, you will get through it. Now, moving on to the prototype LMA, that is LMA Classic. LMA Classic was invented by Archie Brain in 1988. And this is how you have to hold after holding a device, you have to speak about the device, that this is a classic LMA, a first generation cuffed perilaryngeal supraglottic airway device, which is reusable for 40 times. There are 8 sizes of devices available from neonate to adult, and you can describe this device like this. This is an airway tube and this is a mask. There's a 15 mm universal connector. The angle which is formed between the airway tube and the mask is 30 degree. And there's an inflation line, pilot balloon, and a valve. These are the aperture bar which will prevent epiglottis to cause any obstruction in the airway. This is made up of soft silicon non-latex cuff. Now, you should know that size of the device is selected by knowing the weight of the patient, and weight of the patient and size, everything is written on the LMA. Maximum cuff volume you have to remember. For device 1 you will put 4 ml, 1.5 7 ml, for 2 10 ml, 2.5 14 ml, and later on you can just do use this formula, like for 3 number device, 3 minus 1 into 10, that is 20 ml, and so on. Now we'll move on to the step how to put classic LMA. Deflate the device properly, lubricate the posterior surface of the cuff. The patient has to be in sniffing position. Then hold the device in pan holding fashion. The index finger is capped at the junction between the cuff and the airway tube, and thumb is behind. Hold the device in this fashion. Then, after opening the mouth, push the cuff against the hard palate and go inside along the anatomical curve. Push your index finger to the fullest extent into the oral cavity till you feel the resistance. Once you feel the resistance, before taking out this index dominant hand, hold the shaft or airway tube with the non-dominant hand, so that while taking out the dominant hand, the element should not get displaced. Then later on, after inflating the device, connect it to the circuit and check for the ventilation. This is the second device, ProSeal LMA, which was also introduced by Dr. Archibald in 2000. Now this is second generation LMA because here gastric tube has been incorporated. So remember, in the similar way, you have to tell all the devices. LMA ProSeal is a cuffed perilaryngeal second generation supraglottic airway device. And while saying about the anatomy of the device, you start from here. This is the 15 connector, and it has double tube arrangement. One is flexible wire reinforced airway tube, this one, and other one is the gastric tube. What you can see here is a integral bite block. There's a cuff which is made up of silicone. It has a deep bowl, and inside you can see the gastric tube, inner gastric tube. And posteriorly on the cuff, there is a dorsal cuff, which on inflation provide a better seal. There's also an introducer strap where an introducer tube will fit in. This is inflation line, pilot balloon. This is the manual vent and a valve. The manual vent, I'll tell you how and when it is used later on. So this is how you will anatomically describe a device. So whenever you will see any device, you can see so much of information is already written on the device. It is steam autoclavable only. It can be autoclaved for 40 times. You cannot use it for the 41st time. It doesn't contain latex. And the air which should be, with which the cuff should be inflated, since it is a 3-number device, it should be less than 20 ml, which will provide cuff pressure of 60 centimeter of water. And you see, even the weight is given, it can be put in 30 to 50 kg patient. So much information is given on the device. It is also provided with an introducer tool and a defibrillator. There are 7 sizes which are available. Remember that size 1, 1.5, 2, 2.5 have no dorsal cuff. Now we'll discuss the step of insertion one by one. First step is size selection, which will be selected according to the weight of the patient. Coming on to the second step, pre-check. Inspect the device whether the integrity is maintained and there is no breakage in the device. Second is cuff check, inflation and deflation. For inflation and deflation, there are 3 methods in which you can deflate. See, if you don't have deflator, then simply by putting 2 fingers on the cuff, stretch the airway and inflation line and deflate it. Okay. See how beautifully it has been deflated. Second is you can use this deflator device and in similar manner deflate the device. Third one, in case you have ILMA also with you, this is the deflator provided with that. You can use this deflator also in the similar manner to deflate the device. Now moving on to the third step. Third step is putting an introducer tool. Introducer tool, you see, it is mounted here at the introducer strap, which is provided near the cuff. Then engage the introducer tool in this manner. Once you have engaged the introducer tube, lubricate the posterior cuff with water-soluble 2% lignocaine jelly. Fifth step is positioning of the head. Head has to be positioned in sniffing position, and then insertion technique goes like this. After positioning the patient in sniffing position, you have to open the mouth. After opening the mouth, you have to hold the ProSeal LMA through the introducer tool. See, I am holding it through the introducer tool. Then push the cuff against the hard palate and follow the anatomic curve. Disengage the introducer tool and remove it. You have to inflate the cuff. While inflating the cuff, don't touch this device. Don't attach it to any circuit. Sorry. Once it has been inflated, connect to the circuit and push the gastric tube inside. This gastric tube has gone smoothly, which indicates that the device has been placed very nicely and sitting at the upper esophageal inlet. Second, next step is cuff inflation that I have already told you in the video. Then coming to the fixation. Fixation should be done maxilla to maxilla and mandible to mandible. This is how the fixation should be done. This is, he is fixing the tube, the dynaplast maxilla to maxilla first, followed by mandible to mandible. Why? Because it will provide traction, counter traction, and better fixation of the device can be done in such manner. See, this is done, mandible to mandible, then the circuit is connected. Now it is well placed. After placing the device, now the goal is whether it has been placed correctly or not, which can be done in following steps. First is visual assessment. Look for the depth of the device, which should correspond to the integral bite block. Look at the front of the neck. There should be bulging, which should be minimal and symmetrical. Compare the expired tidal volume with the inspired tidal volume. There should not be much difference between them. Peak pressures. Passage of gastric tube is a very good indicator that your device is sitting correctly. There are few tests, suprasternal notch test and gel displacement test. What you have to do in this, put a blob of lignocaine jelly in the gastric tube around 1 centimeter, and then either push on the suprasternal notch to provide positive pressure ventilation. That blob of the lignocaine jelly will move up and down with the respiration. And the gold standard is fiber optic visualization, and Brimacom grading will help you to categorize the placement of the device. Now, recently, ultrasound has been introduced to check for the correct placement of the device. See, in this picture, it is beautifully sitting at the correct position. What are the other techniques? In case you lose your introducer tool, then you can use a bougie or a stellate to guide your ProSeal LMA. Device is removed. While removing the device, suction through the gastric tube and partially pull it out, and remove the device either partially deflated or fully deflated. If you find there are oral secretion, then oral suctioning can be done through the angle of the mouth, and it should be done prior to the deflation of the device. Sterilization, it is sterilized through steam sterilization, that is autoclave at 135 degrees centigrade. Cuff should be deflated and keep the manual vent open. That the red color of vent which I showed you previously, it should be opened. And while putting the device, before putting the device, it should be dried. And maximum 40 sterilizations are allowed. For that, you have to keep a track. Now moving on to oropharyngeal leak pressure. What is airway sealing pressure or the oropharyngeal leak pressure? This is important. Could be asked to you in exam, and you should also understand the concept about it. It is a pressure at which gas leaks around the device during IPPV. So it is very important. If you will keep the pressure beyond that, then the gas will leak and it will cause gastric insufflation, leading to gastric aspiration. How can you measure this pressure? After connecting the device to the circuit, turn off the ventilator, close the IPL valve. Set a fixed gas flow at 3 liters per minute, and you will observe on the ventilatory parameters that gradually airway pressures will keep increasing. Then how will you measure it? There are 3 methods with which you can assess the pressure. First, audible noise can be heard over the mouth of the patient. Or second, if you can connect the manometer and observe the manometer stability. What is that? Observe the Android manometer dial and note the airway pressure at which the dial attains stability. What does it mean? That the airway pressure at which the leak was in equilibrium with the fresh gas flow. So a constant pressure will be seen on the monitor. That will be esophageal leak pressure. Or you can even auscultate to detect the audible noise using a stethoscope placed just lateral to the tracheal cartilage. First generation devices have oropharyngeal leak pressure around 16 to 20 centimeter of water, and second generation have better than first generation, that is around 28 to 30 centimeter of water. Now moving on to the iGel. iGel was devised by Mohammad Aslam Nasir in 2007. And similarly, you can speak about the iGel when it is given to you, that it is a third generation device which has a non-inflatable cuff, and the cuff is anatomically pre-shaped. It is a single-use device. It has an airway tube and a mask which is non-inflatable, anatomically shaped. Airway tube is rigid with an integral bite block and a buccal cavity stabilizer. Here you can see this is epiglottic ridge. And there are here also you can see, I'll show it in a bigger picture, a zoomed picture. Here when you will see this mask, these are the distal opening of the gastric tube and these are the proximal opening of the gastric tube. Remember that size 1 neonatal iGel does not have gastric channel. Here I was talking about this picture. See, it cannot be reused. It is latex free iGel, and this is the black mark which should correspond to the teeth and will tell you the correct insertion of the depth of the device. This is size 4 device which can be used in 50 to 90 kg patient. So here also so much information is given. It is made up of medical grade like thermoplastic elastomer, and it mirrors the anatomy of the airway. It also provides a dynamic seal. So it also falls in category of third generation too. The airway seal improves as the device warms to the body temperature. So with time, the seal will improve. Because it has rigid airway tube, no tool is required to insert the device. It can be put directly along the anatomical curvature. It is available in 7 different sizes. Now moving on to the LMA Fast Track. LMA Fast Track was launched in 1997. Similarly, you describe about this device if it is given to you that it is a first generation device since it has only single airway tube. It is cupped perilaryngeal airway which has been devised for blind intubation. It has a steel handle, a airway tube which is curved at 128-degree angle, and this is the cuff with the epiglottic bar, and it provides success rate of intubation and ventilation around 96%. It is available in 3 sizes, 3, 4, and 5. And this is the tube which is reinforced silicone tracheal tube. The cuff has low volume and high pressure cuff. And this has been beautifully explained in the morning class by Dr. Anchal, so I will not go in detail. This is how you will deflate the LMA. Previously, we have used the deflator for ProSeal also. This is how you are going to deflate the intubating LMA. And before using the intubating LMA, make sure that lubricate the intubating channel of the ILMA as well as the epiglottic bar. These are the steps. Hold it from the steel handle. Put it inside after opening the mouth in neutral position. This can be put even in neutral position. Follow the anatomical curve. Then check for the ventilation. Once you are sure the ventilation is fine, put the endotracheal tube up till the black mark which is provided on the endotracheal tube, and then check for the ventilation. Go in, and in case you are not able to ventilate, what you will do, there are two maneuvers, Chandy's maneuver to manipulate the ILMA. First part is grasp the handle and move it in sagittal plane. Second part is grasp the handle and lift the handle around 45 degrees to above the patient chest, degrees to the patient chest. This will see, once you will lift it up, it will align the cuff aperture to the trachea. It will align the distal aperture of the device to the trachea. So there are two ways, parts of the Chandy's maneuver. Now moving on to the LMS Supreme. LMS Supreme, it was introduced into market in 2007. Similar way, say it is a cuffed perilaryngeal device which is belong to second generation, and it is supraglottic. It has been provided with an innovative second seal, which provide a better seal and resist the folding of the distal end. So this is LMS Supreme. One by one, we will discuss the part of the LMS Supreme. This is airway tube, and this is a gastric tube. It has been provided with a fixation tab. The role of fixation tab is that it will provide an optimal positioning within the oropharynx and hypopharynx with the help of the fixation tube. Next, this is the integral bite block. And see, this is the integral bite block. Further moving down, this you can see, this is a LMA evolution curve. Why it is said so? Because it is elliptical and anatomically shaped, which will facilitate the insertion. Now moving on to the cuff, it is elongated cuff which has two seals. This is the first seal, and here behind you can see the second seal for providing proper seal. When we'll look into the cuff inside, you can see these are the apertures which are known as epiglottic fins. It will prevent the epiglottic downfolding. It is also available in 7 sizes, and the best part is that even the mouth opening of 1.5 to 2 centimeter, this device LMS Supreme can be used. Now moving on to what is Cobra PLA. Cobra PLA, you can see there's a single tube, so it is a first generation device, cuffed, but it is not perilaryngeal. It is pharyngeal supraglottic airway device, which is single use and made up of PVC. You can see here, this is the pharyngeal cuff. It will seal the pharynx. So the ventilating shaft is wider, have more inner diameter, and you can see this has a novel head design. These are the flexible soft grill, and the tip is resembling the cobra head. The function of this tip is to, it will deflect the epiglottis, and these soft grill will provide ventilation as well as instrumentation. You can see a round shape over here. These are the internal ramp which will guide the endotracheal tube through the epiglottis, towards the epiglottis, and the cuff is high volume, low pressure pharyngeal cuff. This is the device, another device which can be provided to you in the exam. This is SLEEPA, the streamliner of the pharyngeal airway is the full form of the device. See, here again, when you are provided with the device, remember you have to say this is SLEEPA, which is a second generation device having anatomically pre-shaped cuff, and it is a supraglottic airway device. Here, if you will define the cuff, it has a toe. Toe will rest on the in the esophageal entrance. These are the bridge. These are the two bridge which will fit into the piriform fossa. This one is heel. Heel will anchor in correct position and connect to the airway tube. This is the airway tube, also known as stem. There is a hollow chamber for collecting the gastric secretion. Now in market, third generation SLEEPA has been also introduced. Why it is called third generation? Because it has perilaryngeal dynamic cuff. That is with the ceiling pressure that will vary dynamically whenever the airway pressure will vary. It also has an additional passage of gastric tube. Now moving on to the laryngeal tube and laryngeal tube suction device. Hope you are not getting confused. Very clear. You have to, whenever you are given a device, you have to name it, you have to classify it, you have to tell about the airway tube, cuff, and then some specific features. So this is a laryngeal tube. You can see it has single tube. It is first generation cuffed pharyngeal sealer, and it is retroglottic because it lies behind below the glottic, and it is fitting in the upper end of the esophagus. You can see the it is available in reusable version as well as in disposable version, which is single use. It has two cuffs. One is oropharyngeal cuff. One is oropharyngeal cuff, another one is esophageal cuff, and the distal end is closed. There are ventilation holes in between the cuff. The tube will be, whenever it is put, it will go into the esophagus, and these ventilatory hole will provide the ventilation, and the air will traverse into the trachea. You can see there are 3 marks here which will tell you about the depth of the tube. Now, what is the difference between the laryngeal tube and laryngeal suction tube? It has become second generation because it has additional lumen posterior to the airway lumen. Here you can see it has an additional lumen which is posterior to the airway lumen. So thus it becomes second generation cuffed pharyngeal sealer, which is retroglottic. The esophageal lumen will open into the esophagus and beyond the distal cuff. You can see the lumen is open over here. It was closed in the LD. There are ventilation holes between the cuffs, and these ventilation holes will allow suctioning as well as passage of the fiber optic. So here also, both the devices have single inflation line for both the cuff. See here also single inflation line is there for both the cuff. However, the difference is that behind the airway tube, there is a additional lumen posterior to the airway lumen, which is known as drain tube. Now, combi tube. It is the difference you can see here from laryngeal tube and laryngeal tube suction, that it has 2 lumens. See, it is second generation cuffed pharyngeal sealer like laryngeal tube suction. However, it is different because it has 2 lumens, a pharyngeal lumen and tracheoesophageal lumen. It has 2 cuffs and it has 2 pilot balloons, two insufflation line to inflate the cuffs separately. There are ventilatory ports in between the cuff, and the distal lumen is open. By default, whenever you will put this combi tube, it will go into esophagus most of the time. If it goes into esophagus, then ventilate through the pharyngeal lumen and inflate both the cuff. Here you have to, for oropharyngeal cuff, you have to put 85 ml of air, and for distal tracheoesophageal cuff, you have to put in 15 ml. So inflate both the cuff and ventilate through these ventilatory pore. The trachea will be ventilated. However, if it is not ventilated in this manner, it means your tube has gone into the trachea, then ventilate through the tracheoesophageal lumen. In the similar way, you will ventilate through the endotracheal tube. So these are the difference. If you have been given compare and contrast LT, LTS and combi tube, you will be able to do it in the exam. This is Busca mask. This is a recent mask which has been launched, a third generation mask, which has a anatomically pre-shaped cuff sealer, and it is a supraglottic device. So why it is called third generation? Because it has a self-sealing membrane cuff. This membrane cuff will adjust to the contour of the mouth and pharynx, and the sealing with the change in the airway pressure, the sealing pressure will also change. It will change its contour. So if you have to describe this device, it has also a unique feature of Pasca mask also have a unique feature of two gastric tubes. You can see one here and other one is here. This is a airway tube. Throughout the airway tube, the integral pipe block is available, which provide it rigidity. And there is a tab. You can see this tab is there, which manually curved, and it provides manually curving of the mask and providing as an aid for easy insertion. Here you can see there is a suction elbow integral to one of the port, and other gastric port is open to the air. So this is how you can describe the Basca mask. This is blockbuster mask. Blockbuster mask is a cuffed perilaryngeal second generation airway device. This is cuffed, which has to be inflated, perilaryngeal, and second generation with gastric tube. So it was introduced in 2012. You can see, you can put in an endotracheal tube, as it can be used as a conduit for intubation also. This is the stabilizing rod provided with it. Here you can see the difference between the blockbuster and fast track LMA. Blockbuster, the angle you can see here, more than 95% angulated. Airway tube is more than 95% angulated, and it is shorter in size, which matches the oropharyngeal curve and provide easy insertion. However, in fast track, the curve is of 128 degree. Okay. Here, when the tube is coming out of the mask, it directs the endotracheal tube towards the laryngeal inlet at the angle of 30 degree with the help of endotracheal guiding ramp. There's a ramp provided in the bowl, which will guide the endotracheal tube at an angle of 30 degree towards the laryngeal inlet. Here, the angle is 40 degree in fast track. There is no epiglottic elevating bar in the blockbuster. However, here, epiglottic elevating bar is present. The second generation device with gastric access, there's a gastric channel. However, in fast track, there is no gastric channel. So you should understand here also one more difference, that there is no guiding handle for the LMA insertion, but there is presence of four-way connector to stabilize the device after insertion. You can see there is a four-way connector to stabilize the device after the insertion. However, here you have been provided with a steel handle, which will guide the LMA, fast track LMAs. Why I have shown this table, that at many times if blockbuster LMA is available in your institute, you may be given these two to compare and contrast. So just to make you aware about the cuff of the mask, I mean to make you aware that when you will see a device, you see the cuff also very nicely. There's difference in each and every cuff. There are aperture bar in the classic LMA. Here you can see the epiglottic bar. This is fast track or intubating LMA. The internal gastric tube is visible in ProSeal LMA. Here you can see the fins. These are fins, epiglottic fins, which are available in LMA Supreme. buccal stabilizer with epiglottic rest. It means it is IGEL. And these are the cobra head with soft grill. It is cobra PLA. So just very nicely see the device. Give some time to yourself and don't get hassled. Just speak the way I've told you. These are the questions which could be asked whenever the device is given to you. Then you have to speak in this manner. The name of the device, the type of the device, classify the device in the exam, tell the material of which it is made. Either it will be of silicone or PVC. Most of the devices which are available, almost all, they are latex free. Then tell the parts of the device, divide it into airway tube and cuff, and then further tell the integrities, nativities of the device, whether it is single use or multiple use. If it is multiple use, what are the methods of sterilization? Once you will speak this much, then you should be assured that you have spoken very well, and you will be asked leading questions. Like you can be asked to compare and contrast the two devices, tell the indication of the supraglottic airway devices, what are the method of insertion, how will you proceed with the insertion. Once you have inserted, how will you confirm for the accurate placement of the device? Then what is cuff pressure and what is esophageal seal pressure? What is the difference between the cuff pressure and esophageal seal pressure? What are the advantages and disadvantages of supraglottic airway devices over the endotracheal tube? What are the troubleshooting? So these are the leading questions. Thank you so much. I hope I have made it clear to you. And if you have any question, then you can ask.
Thank you, Dr. Ramita, for wonderfully designed lecture for PGs.
Thank you, sir.
Covering a whole lot of information. And with this extensive information about the supraglottic devices, I'm sure PGs will be benefited with this. Do we have any questions in chat box?
Yes, sir, there are a few questions in the chat box. So the questions, first question which has been asked is, ma'am, when do we need to insert gastric tube, before inflation or after inflation of the cuff? It can be done in either way. It can be like the way I have shown in the video. I have put the gastric Ryle's tube or suction catheter halfway into the gastric channel, and then I have put in the device, and later on I have pushed it after inflation. However, you can put the device and later on you can put the gastric tube, Ryle's tube through the gastric channel. So it can be done either way. The second question which has been asked is, isn't removal of LMAs preferred with cuff being deflated? Because deflation of cuff will cause secretion to trickle down and can cause laryngospasm. That's true. This is what I told you. Either the device should be removed, either deflated or partially deflated. It cannot be removed fully inflated. So in case you feel there are secretion, oral secretion, then after doing the suction, remove it partially deflated. And in case of reduced mouth opening, then you can fully deflate the device and take it out. The third question which is asked is, can we comment on the MMPG even when mouth opening is restricted? Yes, of course, we can comment. The only thing which is that your eye level should be corresponding to the mouth of opening. And in case whenever the mouth opening is restricted, the MMPG grading will keep increasing. I can see one more question. Is there any role of OLP for iGel? Yes, actually, you might be confused with that since it take with the thermal body temperature, it take shape and further form align with the contour of the oropharynx. But however, whatever is the reason for all the supraglottic airway device, oropharyngeal leak pressure has its own significance because they are not as definitive or gold standard like endotracheal tube. If the device is not placed correctly and if the seal pressure is more than 30, then there will be gastric insufflation and gastric aspiration can occur. There are no further questions, sir.
I think the questions are well answered. And if no further question, we can close the session. And if no further question, we can close the session.
Yes, sir. Thank you, sir. Thank you, sir.
Thank you, sir.
Welcome. Thank you, Dr. Naman. Thank you, Dr. Naman. Before we move on to the last session, which is a presentation on drugs, we will quickly play the video that we were trying to play, but were not fortunate enough. So we will just play the video on surgical cricothyroidotomy, and thereafter we'll start with the last session of, yeah. So here we have the video.
I will be demonstrating you surgical cricothyroidotomy. Again, for this, you need to get ready with all the equipments, suction, emergency drugs. Fine. Now we will proceed with this human mannequin, in which first we will palpate for the landmark. We'll see the most prominent part on the larynx is this thyroid cartilage. First, you will stabilize the larynx with the help of 2 fingers of your left hand, and then you feel for thyroid cartilage. Then slide down your finger like this, and you will feel a gap between the cricoid cartilage, which is this complete circular ring, and in between the two, you will feel for the cricothyroid membrane like this. Fine. If your patient is conscious, then you need to give local anesthetic agent. Fine. And then you will pick up a scalpel blade of preferably 10 to 11 number, and then you will put a horizontal incision like this, and then you take a artery forceps, preferably covered artery forceps, and then you insert the tip of this like that, and you dilate it in first in a horizontal way and then in a vertical way like this. And after dilating this, you take a bougie and insert the curved end of the bougie through this hole and direct it quadrally and till you feel a resistance. Now I am able to feel the resistance. I will stop here and I will take the help from my assistant, who will railroad the ET tube, the cuffed ET tube of appropriate diameter 6.5 or 7 mm through this bougie, and I will stabilize my bougie at this end. It is important to take help from the assistant, and you need to stabilize the bougie, and then you just insert the tube like this and you remove the bougie. Fine. And you inflate the cuff and confirm the correct position by auscultation and by using VTCO2 levels. After this, you have to fix the ET tube with the provided fixing, and that's it about the surgical cricothyroidotomy. Thank you very much.
Thank you, sir. Thank you for the wonderful video.
Thank you, Nitin. And any questions?
I'm sure it gives a clinical and practical. No, sir.
Thank you. Thank you.
Thank you, sir. So we move on to the last session of today's day, day 1, that is drugs on intravenous induction agents. And for this, I would like to invite, we have 2 examiners. First is Dr. N.D. Kaur. Ma'am is professor and the head of department at ABVMS and Dr. RML Hospital. And ma'am's area of interest are clinical, critical care, trauma and resuscitation, airway management, ethics and anesthesia, research and medical education. And I'm sure everyone knows it by now. We have the next examiner. Yeah. Dr. Anchal Kakkar. Ma'am is professor at ABVMS and Dr. RML Hospital. Her achievements are BLS, BCLS and CCLS instructor, ATLS provider. She is a reviewer in JOCP and a member secretary in the Institutional Ethics Committee. Her areas of keen interest are airway management, obstetric anesthesia, trauma, and resuscitation. And they would be talking about the intravenous anesthetic agents. Over to you, ma'am.
Thank you, Nitin. And I would take this opportunity to thank you, Dr. MD Kaur ma'am, our head of the department, under whose guidance we are conducting this 7 days extensive academic program. And in this talk also, it was ma'am's vision and under which I have made this presentation. All the questions, important questions, which usually the examiners ask, ma'am had shared it with me, and I have incorporated them in the PowerPoint presentation, which will be played. And we have tried to incorporate a short mock viva in the end of the presentation, just to give an idea that you may be taken from one drug to another drug, and if you ask leading questions, that will help you perform better. So over to you, Nitin.
Thank you. Can we have the video, please?
Good evening, everyone. I am Dr. Anchal Kakkar, and I will be talking about intravenous induction agents. So